So, good afternoon. Let us look at the adult polycystic kidney disease, a systematic and clinical synthesis we will be doing. Look at that. ADKPD, adult polycystic kidney disease, foundations and cytogenesis. Cystogenesis, very important. Part 1, the definition, KDI-GO 2025 classification, and the genetics also, and pathogenesis. So,
that is cooling, sir. Like it was making some noise. I have kept it 18.
18. Keep it like that. ADPKD, adult polycystic kidney disease. We are now looking at first part, which will be the foundations of the cystogenesis. Part 1, definition, KDI-GO 2025 classification, genetics and pathogenesis. Now you see, most of you people may not know that polycystic disease is a syndrome which involves several other organs. So one important organ is the brain, high risk for intracranial aneurysms. There is a 10% prevalence of intracranial aneurysms in adult polycystic kidney disease. Liver, polycystic liver disease overlap with the ADPLD, adult polycystic liver disease. 83% overlap is there between these two diseases. Heart and vasculature, cardiac valvular defects, particularly mitral valve prolapse or aortic root dilatation may be there. Kidneys, bilateral enlarged kidneys with fluid filled cysts progressively obliterates the normal architecture. Another important thing is this disease does not affect all the glomeruli. It affects only a selective proportion of the glomeruli. So much so the kidney function continues to be good for a long time. ADPKD is the most prevalent monogenic kidney disease. That is single gene producing a kidney disease. This is one good example. Driving about 5 to 10% of global kidney failure cases. So global kidney failure CKD cases, end-stage renal disease, 5 to 10% are contributed by ADPKD. It is fundamentally a disease of structural collapse driven by faulty genetic blueprint. So there is a genetic background, there is a structural collapse of the renal structure. Now let us see ADPKD phenotypes. What are the three types we have? Genetic testing not performed, inconclusive, use standard clinical designation, you call it as ADPKD. Where there is no genetic testing has been done, you have diagnosed with the kidney cystic disease. Second one is the pathogenic variant in the major gene. What are the two major genes? PKD1 and PKD2. So 90% of the genetic cases of ADPKD are either PKD1 or PKD2. So this is when you identify a major gene and the pathogenic variant in minor disease. Where ADPKD, you have several genes there, ADPKD, GAN-AB, and ADPKD, IFT, I140, several smaller minor genes are there. It's important for you to know the genetic variants are basically two types. One is the PKD1 and the other one is PKD2. Diagnosis is no longer just phenotypic. Not only you identify cystic disease in the kidney, you have to identify the genetic background also. Integrating the specific causal gene into the disease name guides prognosis, expected severity, eligibility for disease-modifying therapy, all are dependent upon the genetic diagnosis. It's not only a clinical diagnosis or an imaging diagnosis. It is a genetic diagnosis. Now, in the pediatric manifestations, there are two groups. One is called the VEO-PKD. Other one is called the EO-PKD. What is VEO-PKD? Very early onset and early onset. Very early onset means in utero to first 18 months. So in utero to first 18 months is the very early onset. And early onset is from 18 months to 15 years. This is called the pediatric syndromes are two types. VE-ADPKD, EO-ADPKD. Very early means before 18 months and intrauterine life also. EOPKD is 18 months to 15 years. What are the diagnostic markers here in the VEO? Hyperechogenic enlarged kidneys, more than 2 standard deviations for the gestational age, intrauterine life itself. Oligohydramnios, mother will have. That means the amniotic fluid will be very less, and early hypertension of more than 95th percentile in the mother. So early hypertension, oligohydramnios, and more than 2 standard deviation size of the kidneys compared to the gestational age. Diagnostic markers for EOPKD, enlarged cystic kidneys, more than 2 SD for age, sex and height, severe hypertension, and decreased EGFR also will be seen. Extreme childhood phenotypes are frequently driven by genetic mosaicism, digenic inheritance, or biallelic inheritance. What is biallelic inheritance? There will be 2 genes which are causing the disease, particularly in children. They are somewhat rare. PKD1 hypomorphic allele combined with the loss of function allele. This is called the biallelic mutation or biallelic inheritance. Now, what are the various genetic landscapes of this disease? So, PKD1 and PKD2, these are the major 2 important ones, PKD1 and PKD2, 16p 13.3, 16p 13.3, 16th chromosome, and PKD2, 4q21 and q22. These are the areas where the PKD1 gene and PKD2 genes are there. There are minor genes, DNA JB11, GAN-AB, ALG9, IFT140, ALG5, NEK8. These 6 are the minor genes. They contribute to around 10% of the genetic problem. 90% or more is due to PKD1 and PKD2. So, ADPLD is liver disease, that is adult polycystic liver disease. They overlap with the kidney disease. And the genes there, when there is an overlap, we have got PRKCSH and SEC63 are the 2 genes. There is an overlap there. Advanced next generation sequencing has shattered the 2 gene paradigm. While PKD1 and PKD2 dominate, minor ciliary and endoplasmic reticulum genes now explain the atypical, milder, and non-classical presentations. What did I understand? If it is milder presentation, if it is atypical presentation, if it is a little late onset presentation, probably minor genes are important. If it is typical presentation in the early childhood, either been very early onset VEO or early onset, it could be either PKD1 or PKD2. That's what we have to understand. Now you see, what is the 2 heavyweights, PKD1 and PKD2, what is the difference between them? You may be interested to know. Chromosome size and the size. What is the chromosome? 16p 13.3, 46 angstons is the size. Whereas PKD2, 4q21 is the chromosome. 16p 13, 4q21, 22, 51 angstons. Okay. Encoded protein here is polycystin 1. That's why this is called PC1, polycystin 1, which is a mechanoreceptor. Whereas in PKD2, it is polycystin 2 or PC2, which is the calcium channel problem. Prevalence 75 to 80% are PKD1, only 15% are PKD2. Mutation profile, 60% are truncating mutations. That means the genetic sequence is truncated with severe loss of function. Whereas in PKD2, 83% are truncating. Here, 65% are truncating. What is the median age of onset of end-stage renal disease? By 58 years, usually PKD1 patients will have renal failure, very aggressive disease. Whereas PKD2 is a slowly progressing disease, the median age is 79.7 years. That means these people live little longer. Truncating PKD1 mutations yield the most rapid GFR decline and massive total kidney volume. This is another important measurement you require to know. TKV. This is called total kidney volume, dictating early and aggressive clinical intervention. There are certain differences between PKD1 and PKD2. Now, minor genes, we have several minor genes. One is the IFT140, very mild renal cyst, very low risk of ESKD. GANAP, mild atypical cyst, liver involvement is prominent. ALG9, ALG5, mild to moderate cyst, moderate to late stage CKD will be there. DNA JB11, late onset atypical interstitial fibrosis, smaller cyst, ESKD risk is there. NEK8, severe atypical presentations, kinase domain variants trigger early childhood failure. These are severe. As you move from the left-hand side, mild low risk ESKD to severe high risk ESKD, the minor genes vary. The minor genes frequently lack the massive kidney enlargement seen in ADPKD. Means what? The kidney may not be enlarged. There may not be many cysts, but it could be a minor variant of polycystic kidney disease, mimicking other cystic or fibrotic diseases while carrying distinctly varied risks for kidney failure. So don't be dependent on the size of the kidney or the number of cysts. And whenever you suspect hypertension and there are some amount of 1 or 2 cysts, what you have to see is the other simple cysts or is there a genetic background? You have to see. What is happening? That is the genetic tubular cell, renal tubular cell. That is the little one cilium sensor complex. The cilia are there on the tubular cells. In the cilia sensor complex, there is a PC1 antenna, a large mechanoreceptor, and PC2 is the calcium channel, as you can see the brown color one. So what will happen? Either there is an abnormality in the PC1 or at the PC2 calcium channel. So what will happen? Fluid shear stress binds the cilium, physically activating this. What happens is when the fluid is, look here, when the fluid is moving in the tubule, these have hurt cilia. So what will happen? The cilia will bend because of the fluid movement. When they bend, they trigger the PC1 receptor there. Then automatically there will not be any accumulation of fluid there. Whereas PC1 interacts with the PC2. Once the PC1 is stimulated, it interacts with the PC2 to open the calcium channel. Once the calcium flux is there, there is no more fluid retained here. What is happening here? PC1 mechanism is absent. That means the cilia, when it bends, there is no signal generated. So PC2 channels are not open. So fluid is not moving out. Fluid is retained within the cell and that grows and becomes a cyst-like thing, a bubble. So extracellular calcium rushes in because calcium channels are open, maintaining the intracellular homeostasis and keeping the cytogenic pathways suppressed. PC1 and PC2 complex acts as a cell's physical and chemical antenna. See, look here, the PC1 and PC2 are the two chemical antenna and physical antenna to sense the fluid and see that no fluid accumulates within the renal tubular cell. When one of these two is damaged, either PC1 or PC2, the sensing mechanism is lost and the calcium channels are not open. So much so there will be a retention of fluid within the individual cell and that balloons and produces a cyst. This is the mechanism. Now you see, in calcium 1 and CAMP short circuit. Hit number 1, germline mutation. There are 3 hits here. Hit 1, hit 2 and hit 3. Germline mutation, an inherited fellow is there. He has got a PKD gene, inherited faulty blueprint from the parents. Hit 2, there is a somatic mutation, spontaneous loss of heterozygosity in a single tubular cell. That means one of the tubular cell has mutated and somatically and under the influence of the gene, so much so a focal cyst initiation has started. That is not all. Then the environment also plays a role. Ischemia, hyperglycemia, renal injury, all these things are accelerators and produces what is called accelerated cystogenesis. That is cyst formation. Now, in nutshell, you understand there are three hits. One is the genetic background. Second one is somatic mutation in some of the tubular cells. Then there is a focal cyst formation. Then there is an environmental stress with accelerated cytogenesis. Now let us see the next one. So loss of PC1, PC2 function is there. The first step, that is the cilia of the tubular cell. Then what happened? Calcium influx is blocked. Earlier calcium channels are open because of the PC2. Now calcium channels are not open. Calcium influx is blocked. Removal of the inhibition of the adenylate and cyclase 3, the brakes come off, and then massive CMP spike occurs. Once the CMP is there, it goes on expanding the fluid collection inside the cell. There are four mechanisms: loss of PC1, PC2 function, blocked calcium channels, removal of the adenylate, cyclase 6, and massive cyclic AMP spike. That triggers in the cyst formation. Normal intracellular calcium suppresses adenylate cyclase activity. If you have calcium, cytosolic calcium is there, it suppresses the adenyl cyclase activity. Because there is no calcium, calcium is not allowed to come inside, the channel is not open, lack of calcium, cyclic AMP spike will occur. In AKPD-PD, the cellular calcium deficit unleashes a runway of CAMP production and fundamentally rewiring the epithelial cell from an absorptive to a secretory and proliferatory. Earlier, what is its function? It was an absorptive cell and then try to absorb the fluid from the renal tubule. Now it became a secretory cell and a proliferative cell, and a cyst formation is there. Where is the disease? It is not in the glomerulus. It is in the tubular cell, and not all the tubules are affected. Now, CAMP. What does it do? PKA, MAPK, and ERK cascade will be there. That results in proliferation, inhibition of tuberin, that results in the mTOR activation, and then growth formation, and then shifts away from oxidative phosphorylation and promotes aerobic glycolysis, mitochondrial dysfunction. Cell hoards energy specifically for rapid cyst expansion. So these are the three mechanisms by which CAMP works. We have seen excessive CAMP is produced. And how does it work? It works by PKA and inhibition of tuberin and shift from the oxidative pathway. ADPKD cell reverts to a quasi-malignant phenotype. Now what happened? Just like a malignant cell, it proliferates. But this is quasi-malignant because there are no nuclear changes here of hyperpyknotic nuclei and hyperchromatin and all. Hyperproliferative cell, metabolically altered, structurally unbounded, driving relentlessly fluid secretion and focal cyst expansion. And now the epigenetic drivers. What are the ones which are causing this? The silent disease modifiers. Start from below. DNA hypermethylation, overexpression of the DNA methyltransferase 1. That results in hypermethylation, leads to hypermethylation of the PKD1 gene body and promoters, apparently silencing the regulatory gene. So once the DNA hypermethylation occurs, PKD gene 1 is silenced. The second one is upregulation of the MIR1790 to MIR21 promotes cyst growth, and downregulation of the and other MIR enzymes there and promotes fibrosis. Finally, originally linked only to germ cells, dysregulated piRNAs are now implicated in destabilizing the genome and driving the cystic formation. Now read the box there. Epigenetic reprogramming explains the profound intrafamilial variability in ADPKD. In some families, it's profoundly manifest. In some families, it is not. Why is it? Because the epigenetic reprogramming is different. These mechanisms act as volume dials, amplifying or muffling the primary genetic error. If the genetic error is amplified, you have a very severe disease. If it is muffled, it will be a slow progressing disease. Now what happens? This is the normal tubular endothelium, and there is a deformation, as you see, and then it gets cut off from the renal tubule and becomes its own circular thing, a cyst-like thing. Earlier, the tubule is continuous with the tubule lumen. After it is deformed, it gets detached from the tubule, and no more it doesn't participate in the renal function, and it sorts of grows on its own. Cysts are not merely clusters of growing cells, they are architecturally blind cells. That means they have no connection with the tubule, which have lost their spatial awareness, structural anchors, and connection to the urinary tract. That is why actual collapse of the nephron occurs and detachment from the nephron. These are detached from the nephron. Now, the blueprint, the machinery, and the result. What is the blueprint? Now we know blueprint is germline mutation, PKD1 and PKD2, and of course other minor genes. Epigenetic modifiers, methylation of the RNAs. Somatic hits the third hit. Okay, machinery, ciliary sensory failure, calcium is depleted intracellular, CKAMP search is there, TOR and MAPK hyperactivation occurs, and then metabolism is shifted to anaerobic type of metabolism. Result is loss of planar polarity, fluid secretion, focal cyst expansion, renal fibrosis, and organ failure. ADPKD is a cascade failure, a singular error at the ciliary antenna. PKD1 or PKD2 triggers the metabolic, structural, epigenetic feedback loops that ultimately dismantle the organ from its function. Okay, this is all about the genetics and the pathogenesis. Now, to summarize the whole story, genetics define trajectory of the disease, how fast or how slow. Nomenclature now relies not on anything else but on the genetics. Is it PKD1 or PKD2 or minor gene? You have to identify. Don't stop short at clinical or radiological diagnosis, and you have to make a genetic diagnosis, because the prognosis of PKD1 is much poorer compared to PKD, and minor genetic variants are less dangerous due to vastly different ESKD timelines. PKD1 has got very short timeline, PKD2 less aggressive, minor genes still less aggressive. Pathogenesis is targetable. Why I should know? If I know the cytogenetics driven by ciliary failure or calcium depletion or runaway cyclic AMP or mTOR signaling or change in the metabolic pathway, I have treatment to attack the particular pathogenesis now. Why I need to all this story? Because pathogenesis is targetable by the treatment. Environment is the third hit. So don't just give away that somebody has got genetic ADPKD, nothing can be done now. If you control the metabolic and ischemic stressors actively, you can suppress the genetic acceleration and prolong the life of the patient. This is the message. Now, what is the summary here? We should not stop short with radiological or clinical diagnosis. We have to make a genetic diagnosis. PKD1, worst end-stage renal disease. PKD better, still better will be minor genes. Now, once I know the genetic profile and I have various options of treating that failure, like ciliary failure, calcium depletion, runaway cyclic AMP, or mTOR signaling, any one of those can be targeted by the treatment. And I can control the cardiometabolic risk factors very well and reduce the metabolic and ischemic stress on the already genetically damaged kidneys. That will reduce the first progression. Next part is translating the molecular roots into clinical reality, presentation of the patient, grading, Mayo Clinic image classification, pro-PKD risk stratification and scores, and differential diagnosis. Now, it's the second part, diagnosis, risk stratification, KIDGO 2025, and then management pathways. Evaluate, stratify, and act. Now, you see, is it isolated renal manifestation as on the right-hand side lower part? Or are there cardiovascular systemic manifestations as on the left-hand side? Or are there hepatic manifestations as you see on the top left-hand, right-hand side? Now, What are the cardiovascular manifestations? Intracranial aneurysms, 12.9% prevalence. Okay, thunderclap headache requires immediate attention. Somebody has got a thunderclap headache. It could be a ruptured aneurysm associated with high blood pressure due to polycystic kidney. Other cardiac valvular disease, thoracic aortic aneurysm, abdominal wall hernias. These are the systemic effects. What are the three areas I should look for? Look for cardiac valvular disease, thoracic aortic dilatation and aneurysm, and abdominal wall hernias can be there. Hepatic, polycystic liver disease, most common extrarenal manifestation. 70 to 80% overlap is there. Highly influenced by estrogen. But remember, PLD is estrogen dependent. That means in premenopausal women or in women who are receiving estrogen supplementation, the PLD worsens. So what you have to do, you have to protect from the estrogen. Renal manifestations, multiple bilateral cysts leading to proactive kidney enlargement, complications, coronary, chronic flank pain, gross hematuria, nephrolithiasis, cyst infection. What are the presentations? Chronic flank pain may be there, gross hematuria, nephrolithiasis, and infection of the renal system. Now, VEADPKD. VEO. What is VEO? Very early onset. What are the indicators for that? Antenatal diagnosis of hyperechogenic enlarged kidneys with oligohydramnios. Clinical signs, hypertension more than 95th percentile and reduced eGFR. Intrauterine life itself, it will start. Then EOPADPKD, 18 months to 15 years. Enlarged cystic kidneys are there. Management target blood pressure to less than 50th percentile or less than 110/70. First line therapy with ROS inhibitors. No combination of ACE inhibitor and ARBs. You should not combine. Then adult onset, long silent phase of the structural growth followed by functional decline, typically after the fourth decade. End-stage renal disease is rather late. Formal transition clinics required for young adults. That means we have three types: VEOADPKD, EOADPKD, adult onset ADPKD, clinical presentation wise. Diagnosis wise, PKD1, PKD2, minor genes. Okay, now the matrix you see. ADPKD, HNF1B related disease, acquired cystic kidney disease, simple renal disease. What is the inheritance? ADPKD, autosomal dominant. Likewise, HNF1B related disease, that's also dominant. Acquired kidney disease, not inherited. Simple renal disease, not inherited. Extrarenal features are present in case of ADPKD. What are they? Intracranial aneurysms and polycystic liver disease. These are the extrarenal manifestations. Sometimes abdominal wall hernias also will be there. Whereas HNF1B related, early onset of diabetes, hypomagnesemia, and pancreatic disease may be associated. Acquired cystic kidney disease lacks any cyst, liver cyst. There are no cysts in the liver at all. If you don't find liver cyst and only find kidney cyst or an aneurysm in the brain, without aneurysms in the brain, it is mostly acquired cystic kidney disease. If there is a multi-system involvement is there, mostly it is the genetic variant. Now, simple renal cyst you see in ultrasound, many a time you get the report, there is a simple renal cyst is reported. Just to follow it, absent extrarenal features will be there. Cyst distribution, bilateral and diffuse in ADPKD, variable in case of HNF1B, and acquired cystic kidney disease typically are small and atrophic and they are not enlarged here. Whereas simple renal cyst, usually unilateral, one or two cysts may be there. What is the CKD risk here? Progression to CKD, high risk end-stage kidney disease in ADPKD, variable progression in HNF1B, and acquired cyst occurs late in the disease, CKD will occur, dialysis is late. Whereas in simple renal cyst, there is no progression to end-stage renal disease. You must be able to differentiate ADPKD from HNF1B, acquired cystic kidney disease, and simple renal disease. Now you see total kidney volume. This is a new concept. So instead of taking the measurement of the kidney, you have to work out what is called the height adjusted total kidney volume, HTTKV it is called. So what happens over the period of 20 years to 60 years, the kidney volume starts increasing. But remember, the GFR doesn't fall until 50, 55 years because all the nephrons are not affected. There are certain normal nephrons and they are doing the function. So eGFR reduction or creatinine rise is not a early variable. It occurs late. Rather, total kidney volume progression is a better indicator. Kidneys increase in size exponentially for decades before eGFR shows any functional decline. By the time serum creatinine rises, massive structural damage has already occurred. Advanced imaging genetic calculators are required to predict the decline. It's a very important concept. You should not wait for the renal failure or eGFR to rise or creatinine to rise. You should measure the total kidney volume. So, according to the total kidney volume, HT, that is height adjusted total kidney volume plus age, this is called the Mayo Imaging Classification, MIC, Mayo Imaging Classification. 1A, 1B, 1C, 1D, 1E. 1A, slow progressor. 1B also slow progressor. 1C, rapid progressor. 1D, even rapid, more than 6%. 1E is more than 6% in the increase in the growth of the kidney per year. So very important, this one classification, what is called Mayo Imaging Classification or MIC. You have to measure the height adjusted TKV, total kidney volume, plus the age. Then you get it. Now, you see this is a very important calculator, ProPKD score. So, the genotype-phenotype calculator is very important. PKD truncating mutation is there or not? 4 points. PKD non-truncating mutation, 2 points. PKD2 mutation, no points. Clinical history, hypertension before 35, 2 points. Urological events like hematuria, stone infection before 35, 2 points. Male sex, 1 point. You add all these things. If the points are less than 3, it is low score. 4 to 6, intermediate. 7 to 9, high risk. So there are two scores as you can see. One is the, so now TKV volume, that is total kidney volume plus age is one variable which you have to measure. The second one is the ProPKD score. What is ProPKD? ProPKD is PKD mutation 1, 4 points, non-truncating 2 points, PKD2 mutation 0 points. Hypertension before 35 2 points, urological events 2 points, male gender 1 point. So risk output tiers are 0 to 3 low risk, 4 to 6 intermediate risk, 7 to 9 higher risk. So this you have to obtain both these things. This is a genotype-phenotype calculator. Why? They're part of the genetic manifestations are there, part is the clinical. So genotype-phenotype calculator, the other one is the total kidney volume calculator. Now, I can synthesize, draw a graph, clinical genetic risk score, ProPKD here, anatomical growth, that is the Mayo score, mixed score on the vertical axis. Then 3 boxes are okay. The 4th box, where genetic CKD, ProPKD risk score is high, and also the mix MIC grading is E, anatomical grading is D or E, then that is the rapid progressor. Patients in rapid progressor are anatomically Mayo imaging score 1C, 1D, 1E. ProPKD score more than 60. eGFR decline more than 3 ml per minute per year. Such a case, they are called the rapid progressors. That means what I should do? Actionable. I have to take action immediately according to the KDIGO criteria, KDIGO criteria. So clinical pivot, identifying a rapid progressor, is the primary prerequisite for initiating disease-modifying treatment. Supposing I want to start a disease-modifying treatment, I have to identify rapid progressor. I cannot give DMRs, disease-modifying treatments, for everyone. Tolvaptan is a disease-modifying treatment. I can use only in the rapid progressor versus in the foundational care. For that reason, I require to know who is the rapid progressor. Who is the rapid progressor? Who has pro-PKD score of more than 6 or mixed score, Mayo imaging score of 1C, 1D and 1E. Okay, now you see. Look at the base. Tier 1, lifestyle modifications, dietary sodium restriction, high water intake, to suppress the vasopressin, maintain optimal body weight. That is the lifestyle modification. Second one is inhibition of the renin-angiotensin system using ACE inhibitor or AR. Tier 3 is aged 18 to 49, CKD G1, G2, you target the blood pressure less than 110/70. If the patient is more than 50, titrate the blood pressure to less than 1. So there is a foundational management and self-care are lifestyle, primary pharmacotherapy, BP target. Lifestyle are sodium restriction, water intake to be more, suppress vasopressin, and maintain optimal body weight. Tier 2, use ACE inhibitor or ARP, not a combination. Type 3 or Tier 3 is blood pressure goals. Less than 50 years, 110/75. More than 50 years, less than 120 is the BP target. Now, managing acute complications. What are the acute complications? Cyst infection can occur, fever, localized pain, raised CRP, WBC increased, confirm with imaging, CT, MRI or PET, requires 4 to 6 weeks of antibiotic treatment, not just 1 week or 5 days of antibiotics. Because the infection is difficult to eradicate, at least 4 to 6 weeks of antibiotic treatment is required. Suppose somebody has got chronic flank pain because of cyst enlargement or rupture, shared decision making, stepwise therapy, acetaminophen, non-opioid adjuvants, specialized blocks, spinal cord neuromodulation, avoid NSAID. Gross hematuria is there, cyst rupture or stone, provide proper guidance to avoid unnecessary anxiety. Bed rest and excessive hydration, investigate the cause if it is unresolved. This is acute complications. What are they? Infection, chronic flank pain, and hematuria. Now, disease-modifying therapy, tolvaptan. What is tolvaptan? There is arginine vasopressin is there. This is the vasopressin in the body and also chemically derived vasopressin that goes and acts on V2 receptors in the tubule. This tolvaptan goes and blocks the V2 receptor. So much so, the arginine vasopressin will not be able to act on the receptors. Mechanism, V2 receptor antagonist slows cyst fluid secretion and cell proliferation. Because the receptor is blocked, there is no entry of fluid into the cell. So much so the cell dilatation, cell fluid accumulation is reduced. So, right half initiation algorithm. Gate 1 is the patient a rapid progressor. Who is that? Mayo Clinic C to E or EGFR decline more than 3. Then, what is EGFR? Is it more than 25 or is it between 25 and 60? And what is the age of the patient? Age less than 55, that is gate 2. Age more than 55 to 65 and the GFR is between 25 and 60 with a rapid decline. Then initiate tolvaptan. So when do I initiate tolvaptan? In patients who are rapid progressors, that means Mayo Clinic 1C, Mayo Clinic imaging score MIC is 1C, 1D and 1E. Or GFR decline is more than 3 ml per year. You have got. And if the patient is less than 8, between 18 and 55, and the GFR is more than 25, he is qualified for tolvaptan. Or if the patient is 55 to 65, but the GFR is 25 to 60, and with rapid decline, because of the higher age, they are qualified for 12 factor. Okay. Now what do I do? Naive nephrectomy, hepatectomy, liver intervention. These are the various surgical interventions. Naive nephrectomy means just remove the kidney, polycystic kidney. That is not advised. You should not remove the kidney just like that unless there is a functional indication. Indications for nephrectomy: intractable pain, recurrent infection, suspicion of malignancy, insufficient space for the kidney graft. When do I do? Not before the graft. If you give the renal transplant and after the graft, remove the polycystic. Hand-assisted laparoscopic nephrectomy, it is also called HAL. Hand-assisted laparoscopic nephrectomy is a highly preferred over open surgery. Unilateral is preferred. Timing is pivot. Perform at the time of or after the transplantation and rarely before the transplant. What is this? Nephrectomy. Hepatectomy next. Liver intervention, indications based entirely on the quality of life, impact, and total liver volume, TLV, not organ function. You look at just like you looked at the total kidney volume, here look at the total liver volume. Ranges from cyst fenestrations, sclerotherapy to partial hepatectomy or liver transplant in severe cases, treated only at centers of expertise. Now, what are the advanced disease? Kidney replacement and transplant. Somebody has advanced to end-stage renal disease. He has got hemodialysis, and on the right-hand side, you have got peritoneal dialysis. In between, transplantation is there. So, hemodialysis, standard variable option, viable option, comparable long-term survival. Peritoneal dialysis, PD is not inferior. Don't think peritoneal dialysis is a useless procedure, a myth burster. PD is highly viable to modify the ADPKD. It should not be withheld based solely on kidney size. Only contraindication of if massive abdominopelvic organomegaly is there or unrepairable abdominal wall hernia is there, don't do the peritoneal dialysis. Massive organomegaly and a very big abdominal wall hernias. Other than that, you should try the peritoneal dialysis. And transplantation, optimal route, preemptive living donor kidney transplantation is the absolute optimal therapy. So these are the three, these are called the renal replacement therapy. Both hemodialysis, peritoneal dialysis, and of course the transplant. Now, special considerations about reproductive health and pregnancy. Postpartum review, test the kidney function, reintroduce medication depending on lactation state, return to pre-pregnancy blood pressure, evaluate pelvic floor physical therapy if resuming polyuria indicated to all. Preconception, genetic counseling regarding 50% chance in the child. You have to tell the parents. One of them is ADPKD, it's an autosomal dominant condition. You have to give genetic counseling. 50% of children are going to get the disease. Discussion on pre-implantation genetics diagnosis. Pregnancy and hormones, monitor for preeclampsia and hypertension. Avoid estrogen-based hormones because estrogen therapy, contraceptives, they increase the risk of liver cyst. So estrogen directly drives the polycystic liver disease and cyst growth. Now, multidisciplinary holistic care and pathway. What do I do first? Diagnosis and prognosis, genetic counselor, advanced MRI imaging. Foundational care, primary care, dietitian, salt and weight management. Psychological support, addressing the mental burden and uncertainty of lifelong genetic disease. And you have advanced treatment, nephrologist, 12-Veptan, BP control. Specialized intervention, surgical care, and pain specialist and hepatologist. What is the takeaway? The future of ADPKD management relies on early risk stratification, aggressive foundational care, enrollment into clinical trials. This is important. Now, so a few more slides to close it. The precision management risk to intervention trajectory we are looking at. What are the things? Predict, preserve, intervene, innovate. How do I predict? Stratifying the risk through the precise anatomical, that is the Mayo imaging score, MIC 1A to 1E, and genetic profile proofing, and look at the pro-PKD score also. Measure slowing functional decline via foundational lifestyle changes and targeted pharmacotherapy. Intervene, managing structural failure, intractable pain, navigating the kidney replacement therapy. Innovative, pioneering next generation metabolic and genetic engineering and epigenetic treatments. We'll go one by one. Prognostic matrix, anatomy versus genetics. Mayo imaging classification, MIC, what is the input, height adjusted total kidney volume you will get, and add the age of the patient. Then classify them into 1A to 1E. Core utility, best predictor of future EGFR decline based on the current organomegaly. Pro-PKD score, genetic and clinical model, scoring PKD1, PKD1 non-truncating, PKD2, 2 is 0 points, male sex 1 point. So all these things we add, if it is low, less than 0.3, it is 0 to 3, it is low risk, and 4 to 6 is intermediary, and 7 to 9 is the high risk. It predicts the median age of end-stage renal disease. Now you see here, 1A to 1E. As you move from 1A to 1E, the decoding the Mayo imaging classification, kidneys undergo massive structural expansion for decades before standard functional markers like EGFR begin to decline. So don't wait for the EGFR to decline or the creatinine to rise. So 1A, 1B, slow progressors, that is low risk of early CSKD, conservative monitoring. Rapid progressor, 1C, 1D, 1E, high risk of rapid EGFR decline, primary candidates for disease-modifying therapy like tolvaptan. Now, foundational management, blood pressure targets, dietary sodium, pharmacological therapy, metabolic health. What are the targets? 18 to 49 years, less than 110/75. More than 50 years, less than 120 millimeters of mercury. Home BP monitoring is strongly preferred. Go to pharmacotherapy, first line therapy is ACE inhibitor or ARB, not a combination. Dietary sodium, restrict to less than 5 grams of salt per day, critical for minimizing cystogenesis and fluid retention. Metabolic health, maintain healthy BMI, rigorous avoidance of smoking, and smoking accelerates both the cyst growth and intracranial aneurysm. Now, so this is the tolvaptan story. We already got it. We saw this slide. And finally, pain and complications step pyramid, non-pharmacological therapy, then the supervised pharmacological therapy, avoid MSAIDs, and finally, invasive therapies for refractory cases. We can use the invasive therapies. Now, naive nephrectomy versus surgical indications. Indications are nephrectomy or intractable pain, recurrent severe cyst infection, suspicion of malignancy, insufficient space for kidney, ventral hernia, massive organomegaly. Then, when you want to do it, time it properly. Timing perform at the time of or after the transplantation. Scope, unilateral is strongly preferred over bilateral. Technique, head-assisted laparoscopic approach preferred for open surgery. Now, extrarenal targets. What are the extrarenal targets? Liver, there will be polycystic liver disease, and also there will be abdominal wall hernias may be there. Hernia alert. So surgical repair must be discussed preemptively for patients affecting peritoneal dialysis. Now, what is the gold standard? Kidney replacement therapy. Hemodialysis, peritoneal dialysis. Okay, standard, highly variable option comparing long-term mortality. Peritoneal dialysis readily available. ADPKD, patients cannot use peritoneal dialysis. PD is highly acceptable and valuable. It is only contraindicated in case of massive abdominopelvic organomegaly or severe hernia. Now, top track and bottom track. Top track is for preconception, during pregnancy, postpartum. Okay, counseling and pre-implementation genetic testing in the preconception. During pregnancy, mandatory weekly BP monitoring. Postpartum, pelvic floor physiotherapy recommended for bladder stability. And bottom line, pediatric and adolescents, 0 to 10 years, 10 to 14 years, 50 to 18 years. So we recently had a patient who is a boy around 9 years, and he came with BP, high blood pressure. He fell giddy in the school. The BP was recorded, it was 170 by 110. A boy of ninth class, 9 years, the 5th class or 4th class. Then the parents brought the patient to me. Then we did an ultrasound first to rule out secondary cause of hypertension. We found out it is an adult polycystic kidney. We did a genetic typing. It was PKD1. So now, such a fellow is a rapid progressor and he is a candidate for 12-lepton treatment. But for pediatrics, usually we don't give 12-lepton. Adults, we can liberally give. So we have to weigh the risk in this one. We have put him on ACE inhibitor ARB, one of them, and he is doing better in terms of BP. Not only that, we have to screen the parents, we have to screen the siblings also. We did that. No disease-modifying therapies in pediatrics. Currently, no disease-modifying treatments are accepted in pediatrics. Now, metabolic pipeline, these are called repurposed drugs. That means, for example, metformin, anti-diabetic drug, now it is being repurposed for AMPK activator, currently in phase 3 trials for the IMPED, IMPED PKD trial. PKD IMPED trial, metformin is being tried. Likewise, SGLT2 inhibitors and GLP antagonists are also being tried. These are being repurposed. Diabetic drugs being tried in this condition. Now, gene and epigenetic therapy. Is there any gene therapy available? In the frontier, in future, AAV-mediated gene delivery. That is, delivering the polycystin-1 C-terminal tail to rescue the downstream signaling defects directly in the primary cilium. That means what is the problem? In the cilium, there is polycystin-1 is absent. That's why the PKD1 gene is not functioning. The cilia are no more sensing the fluid and they are now destroyed. You can give a AAV-mediated gene therapy or CRISPR and Cas9 genome editing, in situ editing targeting microRNA binding sites to prevent downregulation of the wild type of PKD1 transcripts. Finally, epigenetic modulators utilizing SMYD2 and EZH2 inhibitors to halt the cyst proliferation cell cycle at the epigenic route. All are possible. Now, what is the clinical blueprint now? Prognosis and monitoring, medical lifestyle, surgical KRT. So, early stage preserved GFR. That means EGFR is preserved early in the stage. Mayo class and PKD or scoring are done. Minor organomegaly and the grade is between 1A, 1B, 1C and not more than that. And pro-PKD scoring is less than 3, 0 to 3. Okay, medical and lifestyle, BP target, salt restriction, avoid combo of ACAR. Now, watchfully waiting for the kidney replacement therapy, monitor for the asymptomatic hernias. Then, if you have a mild stage, declining GFR, that means track the rapid GFR decline of more than 3 ml per minute per year, monitor the LFTs if on 12-lepton. 12-lepton for rapid progressors, we are justified in giving 12-lepton. If rapid progressor, set up the pain pyramid and manage extrarenal signs, assess the liver disease, that is liver cyst, and interventions. Late CKD, ESKD, that is assess KRT viability, kidney replacement therapy viability, and transplantation donor samples. Manage cardiovascular risk, prepare for the KRT transition. And finally, select the dialysis, peritoneal or hemodialysis. Name nephrectomy is not directly indicated. Okay, now. So with that, we have completed this one. Now, I am going to show you some questions so that you will have to answer whatever based on this one. Okay. What is the question? According to the KDIGO guideline, what is the estimated global prevalence of AKPD and its ranking and cause of? We have already told that. So it's around it's a second most common cause, not first most common cause. It is not fourth most common cause, 10th most common cause. It is the fourth most common cause of the disease. The answer is B. Okay. The next one, which genetic variant is associated with most aggressive disease progression? Already I have told you what PKD1 non-truncating, PKD1 truncating, PKD2 and DNA, JB and other minor mutations. Which of that is maximum? PKD1 truncating. PKD1 truncating is the most dangerous mutation. So answer must be C. Okay. Now next you go. At cellular level, what mechanistic model best explains why only 1 to 5% of the nephrons develop cyst despite cells carrying germline mutation? You understand the question? There is a genetic mutation in all the cells, but only 1 to 2% of nephrons only are affected. Why? The second hit hypothesis. First hit is what? Germline mutation. Second hit is what is happening here. Dose threshold model not correct. Mendelian dominant not correct. Viral integration not correct. Second hit is there are certain nephrons wherein the tubular cell loses the ability to secrete fluid and accumulates the fluid, and then so much dilates and forms a cystic space by various mechanisms. One mechanism is what? The PKD1 cilia are not functioning. Calcium channels are not opening, and normally they should open. There is a mTOR receptors are activated. CAMP is excess is produced. All these leads the second hypothesis. What is the third hit? Third hit is the obesity, hypertension, diabetes, cardiometabolic problems, oxygen radicals. All these things also play a role in the worsening. That is the third hit. Now here the answer must be second hit. Answer is A. Let us see the fourth question. Polycystin deficient renal epithelial cells, which signaling molecule undergoes phenotypic switch to become a primary mitogenic stimulus. There are most polycystin deficient renal epithelial cell, the tubular epithelial cell, which signal molecule undergoes a phenotypic switch, cyclic AMP. Answer is cyclic AMP. Cyclic AMP excess is the problem. Now let us see the next question. For at-risk individual between 15 to 39 with a positive family history, what unified ultrasound criteria for diagnosis of AKPD? What are the diagnosis in 15 to 39? What is this type of disease? The very early disease, and adult disease. This is beyond 15 years. So adult disease means what? Here, at least one cyst in each kidney, total of 3 cysts in both the kidneys, 10 or more cysts, kidney length. Kidney length is not important. You must have at least unilateral, bilateral, more than 3 renal cysts. Okay. Now, which imaging biomarker is considered the best existing prognostic biomarker predicting rapid progression and early stage renal disease, aka ADPKD, when GFR is still preserved? What he is asking is, GFR is not yet altered. We can't wait for the GFR to go down. We require some marker. Which particular marker I will use? Imaging marker he is asking. Number of liver cysts, not important. Renal resistive index, not important. Height adjusted total kidney volume, that is the most important. Okay, presence of simple cortical cysts also not important. So height adjusted total kidney volume is the biomarker. That is the answer C. Now, patient is classified as Mayo Imaging IMC 1E. This is according to MIC grading. We have got 1A, 1B, 1C, 1D, 1E. What is the growth rate? Does this subclass represent less than 1.5%, 1 to 5%, 4 to 6%, more than 6%? What is this grade? This is a higher grade, MIC grading. Naturally, the highest amount of rate will be faster growth will be there, more than 6%. Which clinical manifestation is typically the earliest and most common ADP appearing before the age of 30? So he is asking which are the commonest clinical manifestations. A. Hematuria. B. Arterial hypertension. C. Nephrolithiasis. D. Acute flank pain. What is the typical early manifestation? In most common, this is the arterial hypertension. Hematuria is not common. Hypertension, you must look for arterial hypertension. What is the approximate prevalence of intracranial aneurysms in polycystic kidney disease? 1% general population. Okay. Next one is 5%, 2 times higher. 12.9%, approximately 4 to 7 times higher. That is the frequency. C is the answer. Okay. So, in the treatment of polycystic liver disease, PLD, in ADPKD patients, which major driver of faster liver growth rates are important? What do you look at? High salt intake, estrogen exposure, and then male sex and chronic caffeine consumption, which is associated, most liver cysts are associated with estrogen exposure. That means premenopausal status or hormone replacement therapy. Answer is B. Okay. Which minor ADPKD gene is unique because it typically presents with small and interstitial fibrosis rather than significant renal enlargement. Minor genes, they don't produce significant renal enlargement, but they produce fibrosis mostly. What are the genes available here? So here there, IFT140, GANAD, and then DNA JB11 and ALG9. Out of these three, most important thing, which is a small kidneys do not show any enlargement, but fibrosis will be there. The gene is DNA JB11. You have to remember that minor gene. Yeah, C. C is the answer. Based on the 2025 guidelines, which patient would be a candidate for tolvaptan? To whom I will give tolvaptan? Mayo class 1, very mild disease. Mayo class 1 to E, severe disease. Any patient with PKD mutation, that's also minor disease. And then a child under 15, I should not give tolvaptan. So the Mayo class 1C to 1E with GFR more than 25 ml will be the candidate for that. Answer is B. Why? Class 1A, 1B are not serious. 1C, 1EB are the severe ones. PKD2 mutation is not serious. And children we are not supposed to give tolvaptan. So the only remaining thing is Mayo Clinic 1C to 1E. Now, pro-PKD score is used to predict renal survival. Which of the following is a component of the pro-PKD algorithm? What are the things to include? Genetic mutation, truncating, non-truncating we use. If it is truncating, 4 points, non-truncating 2 points, PKD2 0 points, height adjusted total kidney volume. We don't use that is a separate variable. Gender is used, age is also used. Age plus age you have to add. That is why height adjusted total kidney volume is a different measurement. So that you should not combine in the pro-PKD. So B is the answer. Okay. Now 40. Which specific minor gene mutation is associated with severe phenotype led to kidney failure in the childhood? Minor phenotype with severe phenotype with in kidney failure. Answer is NKE8, particularly specific kinase dominant variant. What is the recommended screening modality for intracranial aneurysms in adult polycystic kidney disease? What is the modality used? Contrast enhanced CT, time of flight MRA with gadolinium, conventional cerebral angiography, and then positron emission tomography, PET scan. The best one is gadolinium enhanced MRI is the best one probably to pick up the cerebral aneurysm. Answer is B. I think with this the questions are over. So what I will do is I will circulate the questions also to you. These will appear in your Viva OC, they may be useful, or anywhere they may be useful. So better you have the questions also you have. Okay. So with this probably we will stop here. We have covered, I will share the PDF as well as the video and also the questions. 15 MCQ questions.